TopMedTalk.
Well, hello, I'm Desiree Chappell, and this is TopMedTalk. We are live from the European Anesthesiology Congress EUROANESthesia 2019 here in Vienna. Now, I'm here with the editor-in-chief of TopMedTalk, Monty Mythen. Hello, Monty.
Good to be here, Desiree.
Yeah, it's good for you to be here with us,
Thank
Monty,
you.
this weekend. So this weekend, we're going to be sitting down with presenters, key opinion leaders, and delegates to give you a first-hand look into the Congress. And we've been sitting here this morning. We just started today. And we've had a lot of friends, actually, of TopMedTalk come up and introduce themselves, which is great because
you would appear to be famous.
I am not famous, Monty Mythen. You are famous. It's not me. I think I told our guest that I hope it's not infamy now.
I'm getting tired of people coming up and say, "Is she here?"
You're so crazy. Well, thank you to all of our listeners and all of our supporters. And if you're here at the ESA this weekend, please feel free to stop by. You can join us on TopMedTalk on social media as well and pipe in and give us some feedback. But one of our guests now, our special guest, was one of the guys that came up and introduced himself. So I listen to TopMedTalk all the time, which is great. So we have Alex Butwick from Stanford in the U.S. Alex, how are you?
I'm great. Thanks for inviting me along. This is a great privilege and an honor. Yeah.
Well, what's funny is that you said, I listen to TopMedTalk. We're like, sit down. You're going to be interviewed.
Super. Well, I'm very excited. Thanks for inviting me. This is great.
And that's the Stanford in California, Palo Alto, is it?
That is correct, yes. Stanford University School of Medicine, yeah.
That doesn't sound like that Stanford accent to me.
No, you're absolutely right. You saw them right through me, yeah. So I'm originally from England, as you quite rightly guessed. Trained in England and then came out to do a fellowship in OB anesthesiology at Stanford about 15 years ago.
Oh, it happens.
And then it was not supposed to be for very long, but it turned out to be a good 15 years and it's still ongoing. So, yeah. It's great.
Good place to get stuck.
Yes, it's a great place to get stuck.
I was just saying, there could be worse places.
It could be worse, yeah.
That's fantastic. Well, we were talking a little bit about, you said you've been listening to TopMedTalk?
Yes, that's correct, Love the talks. Fantastic stuff. Always gets me very excited about the world of perioperative medicine. Some of which overlaps with obstetric anesthesia, which I'm guessing you guys want to chat about.
But you called us out on that. You said, don't want to load the bases here, guys, but I'm not sure you're doing enough on obstetrics, which is a good shout. Now we've done more, or we're about to do more.
We're about ready.
That's good. Yeah.
So we do everything.
I know. Well, we have done some on enhanced recovery for OB. Yeah. We talked to Brendan Carvalho, who's actually from Stanford.
Correct.
Last year at ASA. So we've done a little, but thank you so much for sitting down and talk with us. So you said some of your interests right now in practice. So can you dive into that just a little bit more?
Yeah. So my main area of research interest is to do with postpartum hemorrhage. So the work that we've done at Stanford has been predominantly involved in identifying approaches and strategies to better prevent, but probably more importantly, the clinical management of postpartum hemorrhage when it occurs on the labor and delivery unit. And we're looking also complications that are associated with postpartum hemorrhage as well. So as you can imagine, it's a pretty big deal. As you've probably seen in the press, there is, it's very topical right now, the fact that the US, unfortunately and depressingly, has the highest maternal mortality rate compared to other developed countries.
Gosh.
Yeah,
and
that's hard to get your head around, isn't it?
It is astonishing. Yeah, it really is.
We touched on this a little bit with our last discussion about how systems develop and the challenge of the geography and the socioeconomic diversity in the USA. But what do you think? Why?
How long do we have to answer that question?
I know.
What about the 5-minute version?
Yeah, the elevator.
So I think it's there's various reasons why. There's issues from a system standpoint, which is probably one of the main reasons why. There's obviously issues from a hospital level standpoint, provider level, and then there's differences according to the patient populations that you serve as well. So if you factor all of those in, that they probably in combination are major contributors towards the fact that we should be doing a lot better than we are.
Now, I've been to Stanford to Palo Alto, and it looked real fancy to me.
Thank you for saying so.
Well, in the same way that where I work looks real fancy, but it's got in between the little pockets, in between the fancy bits, there are very deprived populations.
Yes, that's right.
Is it those deprived populations where it's happening, or is it broader than that?
Well, there's, as you probably read in the press, there are disparities that we see in terms of the rates of maternal mortality and also morbidity. So it's not just in terms of the deaths that we see, the rates of morbidity amongst women that survive are substantially higher if you come from a minority group.
Yeah.
And in particular, if you're African American.
Right.
Now, the challenge is trying to figure out the why. And the concern is it's not necessarily to do with the background of the patient. It may be more to do with how they're treated at the hospital and the community level. So we're talking about racism as much, if not more so, than the backgrounds that the patients have based upon their race and ethnicity.
Wow, that's fascinating.
Yeah, it's pretty
actually
sad, right?
really scary.
I know. I really put a downbeat on this conversation. It wasn't intentional.
It's
reality.
It's a very common discussion point we have on TopMedTalk. I mean, we're quite a transatlantic setup.
Right.
So we do a lot of reflection comparing Europe, but in particular the English National Health Service, to the state of play in the United States of America.
Yeah.
And the conclusion we seem to commonly reach is you can buy the best healthcare in the world in the United States of America, but on average, it just ain't that good.
Yeah, and it's a real shame. And I think there's lots of opportunities to do better, as you can probably guess. And there are national societies, certainly obstetric societies and the anesthesia societies are now realizing this. So there are examples of mechanisms that they've tried to put into play to try and improve the quality of care at the provider level and the hospital level. So, for example, postpartum hemorrhage. There we go. That's a classic example. So the Council for Maternal Safety in the US...
So time out for 1 second, because we've got to remember our lay listeners. Nick's looking at me and say, what are they talking about?
Oh.
Right?
Okay.
So that means bleeding heavily after you've had a baby.
Yes, that is correct. Yes. So bleeding that is not controlled well, at least after delivery, that results in major end organ injury or major organ injury dysfunction, resulting in potentially death if it's not adequately dealt with or addressed.
So it affects the rest of your body.
And in the current system, is it unusual to die at the time you're bleeding? Is it more common to die of the consequences of having the big bleed? Do the carers usually get there in time to stop the death from the bleeding, or is it still a mixed bag?
Well, there's new data out from the Center for Disease Control where they've actually been able to look at the frequencies, the causes, and how they vary in terms of the contribution to death by the time period at or after delivery. And as you're alluding to, postpartum hemorrhage is now been identified as the leading cause of maternal death during the early period after delivery. I think it's within that up to that 1 week period. And I would imagine that most of those deaths are occurring very soon after the onset of blood loss.
So some mums have the bleed, a big bleed.
Yeah.
They get scooped up successfully there, but not necessarily scooped right up, and they die from the consequences of it in the wake of that. The way in which we can identify the reasons why, there's less information about that, but California, through the California Maternal Quality Care Collaborative, have tried to identify reasons as to why, and many of the causes are resulting are due to substandard care or denial or delay initiating care. And as a result, postpartum hemorrhage has now been identified as the most common preventable cause of maternal death. So 70% of deaths from postpartum hemorrhage have been deemed to be preventable.
Oh, gosh, that's so scary.
Now, obviously, some of those can happen, actually. They can present late.
Sure.
So the patient can go home, and then a week later or so they may have a bleeding event, but most seem to be occurring fairly soon after delivery.
Did you say this? What is the rate of hemorrhage, postpartum hemorrhage?
In general?
Yeah. I mean, is this like a common problem? I mean, obviously
it seems to vary depending upon the paper you look at. So whether it's population-wide or they're based on a region or a single center. But we feel it's somewhere between probably like 2 to 3%, with the rates being lower if you're interested in severe PPH. Now, often what they'll do is they'll look at claims data, and if you have an ICD-9 code for postpartum hemorrhage accompanied by a transfusion code, then if you're using those two criteria to define severe PPH, it's probably less than 1%.
Yeah, so rare but catastrophic.
To repackage that, so I work mainly on intensive care. And our unit supports a major central London obstetric unit. So when I was working on the main unit, we saw the bad end of the spectrum of the severe PPHs. But I think what you're saying is most of it is a disturbing bleed that results in resuscitation and the administration of maybe 1 or 2 bags of blood. That's the sort of the less commonly seen severe end of the market. Now, do they have a higher mortality rate as well, as opposed to the, oh my goodness, this is really going badly wrong, gallons of blood, literally gallons of blood and intensive care? Is the spectrum, that what happens next, worse, I'm assuming, at one end of the spectrum compared to the other, but is being anywhere on the spectrum a risk?
Yeah, I mean, I think we need to be vigilant for it, and I think part of the problem is, I think the answer is yes.
Yeah, okay.
And the challenge is trying to identify all patients at risk for PPH. At least from an epidemiological standpoint, the data suggests that possibly 40% of patients that have severe PPH don't have any obvious identifiable risk factors. Now, it's easy to find those patients that have suspected placenta previa or abnormal placentation with an accretor. Those patients, unfortunately, are becoming increasingly common, and we know that they are certainly very high risk for severe postpartum hemorrhage.
So to repackage that again, so usually the placenta sits away from the birth canal. It sits in a nice place that means it's not getting in the way of the whole process. Mm-hmm. But if you're unlucky, it can sit right across the birth canal or near the birth canal, or just be...
You mean from a...
Because there's a lot of clever terms we just used there.
Yeah, I was just say accreta and all these things.
So I think if it's overlying the cervical os, so it's incomplete or completely overlying the cervical os, then that's a problem. So if you, to give you an idea, or if you have a previa in your current or index pregnancy, obviously we've seen an increase over time in the rates of cesarean section in the US, and that's occurring in other countries. So if you have a previa in your index pregnancy and you've had 2 prior cesarean sections, from an epidemiological standpoint, your risk of accretor is about 40%. If you've had 3 prior cesarean sections, it goes up to about 60%. So not surprisingly, at Stanford, we are seeing an increase in referrals of patients with abnormal placentation, because they really need to be dealt with in tertiary obstetrical centres or at least a centre that deals with the high volume of these patients. And I think you've seen that probably in other high-risk surgeries as well. The places where patients do better tend to be in places where they do these procedures more commonly.
Yeah, of course. Well, going back to what we were saying earlier, we got off track a little bit, but what are some of these organizations that represent obstetrics and anesthesiology doing to help with these issues?
Right. So they recognize certainly there are major variations in practice.
Yeah.
And also there are big differences in terms of the resources and the equipment that is available at a hospital level. And I think it's probably a challenge if you live or work in a rural setting or a small community hospital where you just don't have the equipment, a good blood bank, in-house staff. So even if you've got the best will in the world, those problems are difficult to rectify. But you can try to standardize practice. So the agencies that you're talking about, the Council for Maternal Safety, they're made up of representatives from a number of different maternal care and obstetric organizations, and there's a SOAP representative on that committee as well.
SOAP is the...
is the Society for Obstetrical Anesthesiology and Perinatology.
Yeah.
And individual states, spearheaded initially by California. California has an organization called the California Maternal Quality Care Collaborative. The aim of that organization is to reduce preventable, at least, maternal morbidity and mortality. Not surprisingly, one of their first bundles of care, one of their first series of recommendations was to do with an approach to better recognize, deal with, and manage postpartum hemorrhage. So those bundles have now been put out by these organizations, and they're certainly improving practice in California. And actually, we've seen a decrease in rates of morbidity from hemorrhage as a consequence of this. So much so that I hear that JCO, the Joint Commission, will be releasing or planning to release a new proposal for standards of care in perinatology. And within those new standards, the expectation is they'll be laying down a series of recommendations for how patients should be managed that have preeclampsia and postpartum hemorrhage. So if that's going to impact hospital accreditation, if you ain't already doing it, you may have to if they rubber stamp these proposals.
Yeah, you better get on the front of that one too, because you don't want to be on the back end of it.
Correct, yeah. So watch this space.
Are there still planned home births in the USA? This is still a debate in the UK. And is that purely a cultural decision, or sometimes is it a financial decision?
Oh, that's a really good question.
Before the NHS, it was an opportunistic or a financial decision.
Right.
Cut short, call the midwife, but have you got the money?
So this is just an opinion, and it's not going to be a very experienced opinion. But I think you are correct. A lot of patients that choose to have a home birth, say you live in a urban or metropolitan area, you have hopefully, if you have insurance,
maybe.
If you're lucky enough to have insurance,
yeah.
then you may have the luxury of choice. So then it's probably more likely to be a personal decision. But there are, from my understanding, a set of criteria that you need to meet to be a candidate for a home birth. So healthy patient with no pre-existing significant medical diseases, no pregnancy-related disorders, with a healthy baby whose pregnancy is advancing normally. So there are opportunities for those patients to consider either a home birth or a birth in a birth center. Now, you may find that in patients that live in a rural setting where they are, 50 miles away from the nearest hospital, as you may have seen, there are hospitals that are closing in rural centers. Well, not sorry, I'll rephrase that. There are labor and delivery units that are closing because the hospitals can't afford to run them. Yeah. And so the patients that are living in these rural centers are having to consider a long drive to get to a labor and delivery unit.
Yes. Yeah. That's where I grew up, actually. I'm from Kentucky and southern Indiana, and there are some units that are closing down, and it's like 45 minutes, to the closest L&D.
So this is a big... the US major news outlets have basically got hold of this, and it is now a major head-grabbing news in terms of I guess we can call it the maternal mortality and morbidity crisis in the US. You've seen stories in the New York Times, USA Today, ProPublica. It is a big-ticket item right now. Yeah. And luckily, there's laws that have just been passed to try and at least identify the reasons why the maternal death rate is so high. So we're going to be seeing more states, hopefully, getting funding to have maternal mortality review committees.
Yeah.
Has the president spoken out about it? You don't have to answer that in any great detail, but I would have thought he'd be straight onto that he's got strong opinions about healthcare.
Has he spoken? Well, he's signed the bill, for at least funding to go to states for setting up these mortality review committees. Yeah. So I'd say that's more than enough.
Absolutely.
That's something. Yeah, give them some money. And that's what they, that's what they states.
But obviously there's still
that.
room to do more. So it's not just a matter of figuring out why we need systems in place to try and help hospitals to do a lot better than they do.
Yeah. Well, Alex, before we go, because we're going to wrap up here shortly, I see that you're faculty here.
Yes.
So what are you doing? What's your role here?
Well, I've just finished a talk on postpartum hemorrhage on session 1 at the meeting.
I know.
Okay, so it was actually a talk with Jean-Francois Petit, who was part of the ANA. So there was a talk on neurosurgical bleeding from neurosurgical or trauma from a neurosurgical standpoint. There was Jean-Francois talked about trauma associated with bleeding, and then yours truly talked about postpartum hemorrhage. I got 15 minutes, which I thought was pretty good.
Hey, 15 minutes is good. Yeah. Well, cool. Well, very good. Well, I can't even thank you enough for coming up and introducing yourself.
Well, this has been great.
I
really enjoyed this.
You'll be able to listen to yourself on TopMedTalk soon.
I know. Yes.
You might get that. Are we getting it out today, Nick? Get this out today?
Yeah. It'll go out.
And I'd love to put a quick plug out for our society. I'm the secretary of the Society of Obstetric, Anesthesia and Perinatology. The meeting is really good, and we cover a lot of these topics. So
when is it?
Yeah, Nick gets the link, and he'll put it in the
show notes. So the next meeting is next May. It's in Halifax, Nova Scotia. It should be a great meeting. I know the people that are organising it, Ruth Landau and Ron George. It's going to be a fantastic meeting. I'd encourage anyone out there that likes OB anesthesia to come. You'll hear lots about hemorrhage and other juicy OB and OB anesthesia topics.
And the website?
I think it's soap.org.
We'll put it up there for you.
We'll find out for you.
Okay, fine, thanks. I can't remember the exact URL.
And you said there are guidelines that are be coming out.
Yeah, I mean, there are consensus statements that have appeared on the neuraxial anesthesia with patients that are anticoagulated. There's a new one that's just come out on ERAC, enhanced recovery after C-section. There just another one come out about what to do for dealing with neuraxial morphine after C-section and respiratory depression. That's just come out in ANA ahead of print. And they're working on one for thrombocytopenia in OB patients as well. So SOAP is very active now in making sure they're having a voice to help providers in dealing with these type of scenarios.
Yeah, fantastic.
Yeah,
thank you so much. Yeah.
No problem. This has been delightful. Thank you so much.
So be sure, and I don't know, we didn't necessarily tell you before, Alex, but we've been streaming, audio streaming.
No idea. Oh, wow.
So the world's been listening.
I thought it was nice.
It sounded great. It was great. So thanks to all that have been listening. Be sure to follow us on social media, Twitter, Facebook, LinkedIn, and Instagram. We're going to be posting some pics up there. And be sure to subscribe to TopMedTalk on TopMedTalk.com on your favorite podcatcher. And most of all, please share with friends and colleagues, residents, fellows. Start helping us spread the word about perioperative medicine and improving healthcare. So thanks so much. Thanks again, Alex.
Okay, my pleasure. Thanks again.
Cheers.
Bye-bye.
TopMedTalk.
Nick Majerison here. Thanks for listening to TopMedTalk. Now, before we let you go, it's important that we remind you to subscribe to TopMedTalk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out TopMedTalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. TopMedTalk.com and click on the section marked email updates. Finally, TopMedTalk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on TopMedTalk. That's ebpom.org/meetings.